as you can see, I've been asked to talk about the medical management of chronic pain. I have no disclosures relevant to this, and over the next 10 minutes I will try to provide an overview of this arguably very complex topic and give you some basic take-home messages. According to the IASP, chronic pain is a pain that persists or recurs for more than 3 months. And now there are a number of variations of this definition, but essentially it is pain that lasts longer than the expected healing time for an injury or continues in the presence of an ongoing process that damages tissues. So something like chronic arthritis would be an example of chronic pain in the setting of ongoing tissue damage. The burden of pain is difficult to quantify, partially because the definitions vary, but it has been estimated that about 10% of the world's population suffers from chronic pain. There was a WHO study of 15 countries that found that chronic pain affected a mean of 22% of the population in those countries that were studied. The IASP has subdivided chronic pain into chronic primary pain and chronic secondary pain. Chronic primary pain was meant to include pain conditions with obscure etiology characterized by complex interplay of biological, psychological, and social factors. So things like chronic widespread pain, fibromyalgia, complex regional pain syndrome type 1, irritable bowel syndrome, and in fact most chronic back and neck conditions would fit into this category. The secondary pain conditions, on the other hand, have a clearly identifiable etiology. So cancer pain, trauma, post-traumatic pain, pain following neurological injury. Some have chosen to separate cancer pain from non-cancer pain and then talk about non-cancer pain in the setting of neuropathic or nociceptive. In my mind, this confuses pain etiology, so cancer pain is really an etiology, not a physiology, from physiology. So when I talk about chronic pain, I prefer to divide chronic pain into nociceptive pain and neuropathic pain. Nociceptive pain is pain from tissue damage, and it's pain that's transmitted along normal pain pathways. And it can be further subdivided into somatic pain, so that's pain arising from cutaneous or muscular or osseous structures like arthritic pain, and the pain of degenerative disc disease, and visceral pain, which arises from the viscera and from the peritoneum. Neuropathic pain, on the other hand, is pain that is initiated or caused by a primary lesion or dysfunction in the nervous system. And it can be subdivided into central pain and peripheral neuropathic pain depending on the level of injury. This becomes relevant because I think the different types of pain require a different way of thinking about their medical therapy. Nociceptive pain responds best to things like analgesics, nonsteroidal anti-inflammatories, and opioid medications. Now, additional benefit can be seen with the addition of adjuvants like antidepressants, some of the anticonvulsants, and some cannabinoids. For neuropathic pain, on the other hand, the first-line drugs would be antidepressants and anticonvulsants. The antidepressants that are most effective are tricyclics, like amitriptyline and dizipramine, the SNRIs like duloxetine and venlafaxine. Now, many would consider using cannabinoids as a next step, and some of their analogs which are commercially available. There are at present no robust data to support the use of chronic opioids for neuropathic pain, but that being said, it's considered acceptable practice to supplement the above therapy with the selective use of opioids. When treating patients with chronic pain, it's important to set goals and to manage expectations. And we use the same principles when we're looking whether it's medication management or whether it's things like spinal stimulation. Pain elimination is not a reasonable expectation. A reasonable goal would be to reduce pain by at least 30%, but with that see an associated improvement in daily function and quality of life. Patients should also be made aware that if the medications, particularly opioid medications, are not sufficiently effective, then they should be tapered and discontinued. With respect to opioid medications, for mild to moderate pain, codeine or tramadol are probably the first-line medications, and second-line meds would be low-dose morphine, oxycodone, hydromorphone. When you get into severe pain, then morphine, oxycodone, and hydromorphone are first-line medications. Fentanyl is the second-line medication. and needs to be used with some cautions and caveats. You should never go directly from codeine to fentanyl, as some patients have little to no opioid tolerance, even if they've been on chronic use of codeine for a long period of time. Patients must have been taking somewhere in the range of 60 to 90 morphine equivalents daily for at least 2 weeks prior to considering fentanyl therapy in order to risk or avoid the risk of overdosing. And a reasonable starting dose would be like 25 micrograms per hour. Methadone is the third line med, and it should be titrated very slowly as there is a high risk of overdose due to its very long half-life. Immediate release opioids are good for the initial opioid titration and for the treatment of breakthrough pain. And they can be used instead of continuous release opioids for recurrent pain that lasts a few hours or for activity-related pain. Continuous release opioids are useful for long-term use in patients with pain that is ongoing throughout the day. Now, having said that, there's really no evidence that continuous release opioids are any better than immediate release opioids for chronic pain, as long as the immediate release opioids are taken around the clock on a time contingent basis rather than a PRN basis. If opioids are not producing satisfactory relief, then they should be tapered and discontinued, rather than simply adding another medication on top of them. During dose reduction, some patients, interestingly, find that their analgesia improves on a lower dose. There's a well-known phenomenon referred to as opioid-induced hyperalgesia, and as you drop the dose of opioids, their pain may in fact get better as they reduce their dosage. The rate at which opioids can be reduced is quite variable, but it can be as much as 10% per day. The WHO analgesic ladder was proposed in 1986 as a tool for the management of cancer pain. It was also applied to acute and chronic non-cancer pain. And whereas this is a good starting place for the management of chronic pain, in jumping from mild pain to moderate pain to severe pain and increasing the types of medications you can use, this only deals with medication therapy. And there have been a number of modifications of this ladder, but you saw this in the introductory talk as well. This has been modified over time, and this particular version of the ladder, published in 2020, allows for minimally invasive interventions. So things like epidural steroids, facet joint injections, medial branch ablations, TENS machine, spinal cord stimulator. These interventions should be undertaken when pain is not controlled by weak opioid analgesics. That is, before you start moving on to strong opioid analgesics, is a good time to start introducing these ancillary therapies. With this analgesic ladder, it also includes the addition of integrative medicine therapy. So it encourages the use of such modalities as chiropractic, osteopathy, naturopathy, acupuncture, meditation, yoga, massage therapy can all be added into this as an augmentation of the medication management. So to sum up briefly, there are a few things I wanted to emphasize in this brief talk. I think first, we should mentally distinguish between nociceptive pain and neuropathic pain, accepting that there are going to be pain types that are kind of a mixture of both. But look at the difference between the two. Nociceptive pain responds best to analgesics and opioids. You can add in these other adjuvant medications to try to supplement that. For neuropathic pain, on the other hand, your mainstay of therapy is antidepressants, anticonvulsants, and then the cautious use of opioids to supplement that if needed. It's clear that one should set very clear treatment goals and manage patient expectations up front. And one should consider minimally invasive interventions to supplement medication before moving on to strong opioids. So with that, thank you for your attention.